to VBA staff. And the people also offered literally hundreds of comments, sometimes up to 600 comments per question, which added very rich detail to the picture that we got. And to contextualize further, the Secretary of the VA has said that he, in spite of the fact that that a report he made says very categorically that the Mission Act, the Veterans Community Care Program, is causing more delays in care, fragmentation of care, has lower quality care and costs more. The Secretary insists that he will not revise any of the drive time or wait time standards imposed on by prior Secretary Wilkie, because there's healthy competition. Having the VA in-house care and the Veterans Community Care Program creates healthy competition. But this report distinctly shows, as do other reports from the VA OIG, the GAO, as well as other scientific studies that have appeared in many journals, that the kind of level playing field that creates healthy competition is absent when it comes to the VA and outsourced care to the private sector, and that the VA is distinctly disadvantaged, and therefore veterans are disadvantaged. And what we found, just briefly, and then people are going to go into this more, is serious understaffing and staffing shortages that way before the Air Commission appeared on the horizon have forced closures of programs, beds, services all throughout the country. We found that in the face of massive staffing shortages, that people are being moved from delivering direct care to veterans to serving as insurance company utilization reviewers in the Office of Community Care, and also now in something called the referral coordination, which adds yet another level of people being taken away from direct care roles, which then creates delays in care and more outsourcing. As Jim Martin will talk about, he's an emergency physician. This creates a dangerous fragmentation of care, having veterans move from the private sector system to back to the VA creates a dangerous fragmentation of care. Fragmentation of care is a very serious problem in the American healthcare system for all of us who are not VA patients. VA patients used to be sheltered from this. They are no longer sheltered from this kind of fragmentation of care. And then there's a lot of burnout because of feeling understaffed, under-resourced, overwhelmed. A staggering amount of people in the VHA said that they were considering leaving their jobs and would if they could afford it. That's not very good when we think of the amount of staff we need for the PACT Act. When we look at the VBA, we see the same sort of problems. Jasper's going to talk about that in a minute. So that is a sort of broad picture, and we're going to look at people who are going to explain a bit more and go into more depth about these problems. And then I'm going to conclude by looking at what we recommended in the report and then open it up for discussion. So the first person who's going to speak is Russell Lemley, who's can introduce himself. He's a co-founder of VHPI and a senior policy analyst along with me, and he worked in the VA in San Francisco for 37 years in delivering mental health care to veterans. And he's going to talk about the problems that the Mission Act and other initiatives have created in the VA and for VA staff. Russell.
Okay, well, thanks, Suzanne, and hi, everybody. I wanted to say a couple things even before I talk briefly. One is that the questionnaire that we sent out, Suzanne was talking about the 40 questions or so that were in our questionnaire. We're not able to actually determine which of the respondents work in mental health per se. And so I'm going to talk a little bit about the report, and a little bit about some of the pieces that we also know from other data as well that complement what some of the kind of side comments were that we found in the report. There are ways that we can go into the report and kind of identify more particulars, particularly in terms of physicians and nurses, because that was a category that we asked. I'm going to be summarizing kind of in a little bit more of a global way. The other thing I want to just say at the outset is that in spite of kind of considerable difficulties that we found across the report that Suzanne just summarized and we'll talk more about today, is that I think all of us in VHPI see that the Veterans Health Administration, the Veterans Benefit Administration are still the cream of the crop. I mean, we are very strong advocates, strong supporters. This particular report doesn't talk about all its strengths, but we have written for years and years about ways in which the healthcare delivered by the VA is the best in the country. I don't want to kind of fail to mention it here, because really, as strong advocates of the VA system, that the report is written with ways in which we think it could be even better. So with that, let me just pivot and say that some of the things I'm going to say in the next couple of minutes are all in the report itself. I'm going to be talking only about issues related to mental health. We allude to a 2022 OIG report that talks about over half of all of the VA medical centers had what are called severe shortages of psychologists. Over half had severe shortages of psychiatrists. And that's actually been true for the last 8 years since the very beginning of the Choice Act. So this is a chronic problem, and it has a lot to do with what we report in our report, because the shortages of staff, and it isn't just in mental health, the shortages of staff are what are driving a considerable amount of the problems that we were able to detect through the survey. I will just say, as a psychologist, one of the things that's also in the report is that as of just last quarter, there's still 1,300 psychologist vacancies. And this is just one of the other ways of talking about shortages of staffing. We also talked a little bit about something that has been chronically going on since the VA issued its Directive 1161. That's a directive that says there needs to be a minimum of 7.72 full-time outpatient clinical mental health professionals per 1,000 mental health patients. And more than half of facilities, this in terms of the last report that we have on that directive, have not met the VA's own directive. So we know that when that's a ratio that is attained, has been shown to prevent suicide, it also increases care delivery. And I guess, Suzanne, we can talk later that one of the strong recommendations that we have from the report is that the VA's own directive be adhered to. We talk a little bit in the report about a GAO 2021 report that talks about what happens when you push your staff too hard. It's interesting that GAO took a look at this, and they were talking about how excessive patient loads have a direct relationship to staff burnout and high turnover. And I think that it's clearly one of the take-home messages that we found throughout this entire report that we sent, but it's something that echoes what the GAO had said as well. And that was true kind of across the board. And then there's something very particular that they, in a different 2021
Is Russell out for everybody or just me? He's out. Okay. Well,
He's out for me too. He's frozen.
Me too.
All right. All right. Suzanne, do you want to sort of talk about some of the VHA findings until Russell gets back online? Suzanne? No?
Yes, I will. Sorry. Essentially, there was a very worrisome responses to survey questions about loss of mental health staff, about people feeling burnt out, about the diversion of patients into the private sector and the poor quality of care that was being delivered there, and people coming back into the VA with exacerbated problems because they weren't getting the kind of care that they needed. For example, CBT for insomnia, patients would be referred out into the private sector, and there are no psychologists or mental health professionals doing CBTI for insomnia, so they would be given talk therapy, which isn't as effective, and that those are the kinds of problems that occurred. I mean, it was very worrisome about the fact that staff were leaving, were not being replaced. One of the things that the report looked at was the problems that were created by the Human Resources Modernization Project, which the Trump administration initiated, and the Biden administration has refused consistently to reverse. And these had a very strong impact on hiring psychiatrists, psychologists, social workers, and other mental health professionals. I hope Russell will rejoin us. I think he's having an internet problem. And I think we should move along, and he can jump in into the discussion as it moves along. I think we should move to Jasper and Dave Bump, who will talk a little bit about the VBA side of the report. So Jasper, do you want to lead off and then turn it over to Dave?
Sure. Yeah. Thanks. So, I mean, there are a lot of like specific statistics throughout our survey based on the results we got. And, we broke those down between the Veterans Benefit Administration and the Veterans Health Administration. I just want to quickly tick off a couple of statistics from the Veterans Benefits Administration, which are very closely mirrored inside VHA. But for instance, roughly 80% of survey respondents who work in the VBA said their departments desperately need new staff. Nearly 60% said the agency isn't actively recruiting to fill important roles. The VBA today is struggling with nearly 3,000 open positions, which, as we've alluded to earlier, does not bode well as the VA prepares to implement the PACT Act, which is this massive new expansion of eligibility for veterans who've been exposed to toxic exposures over the last few decades. Over 50% of VBA respondents said there were vacant positions for which no recruitment is taking place. 53% said they had lost staff because of salary ceilings. 80% said they had lost staff because of signing bonuses and financial incentives. One of the specific issues within VBA is that in this sort of environment of understaffing and under-resourcing, the needs and the veteran claims are not abiding. And so what has happened is that these hardworking folks, many of whom are themselves veterans, are facing intense quotas that are really impossible to meet. Now, some of these various metrics were introduced during the Trump administration. Many remain. According to our survey results, 80% of VBA staff say they face workplace quotas and productivity measures. People talk to us about how the environment feels like a production line or a sweatshop. There is just a really intense pressure to evaluate claims and move them forward, even for very complex claims that often require, a lot of time on the phone with a veteran, walking them through what is required to basically get into the front door of the VA. And so I think Dave Bump can sort of speak a bit more about, some of these challenges within the VBA and, sort of especially, how they're being exacerbated as VA leadership on high is really trying to get implementation of the PACT Act underway. So Dave, if you want to take it from here, that'd be great.
Dave, is Dave there?
He's here. I can keep talking.
No, sorry. I was actually on the phone. My brother called me. My brother, who's a a Gulf War veteran, had just called me. I've been trying to help him work through his claim. So he had to have he wouldn't mind me sharing this because I'm not going to give you his name. He had to have a kidney removed because it was cancerous. And this is illustrative of what's going on with specifically the outsourcing of the exams, the comp and pen exams. He was outsourced to a contractor, and despite all of his care, including the operation to have his kidney removed, all of it being done at VA, he was sent to a contractor, and when he got his rating for his claim under the PACT Act, the examiner never even addressed the fact that he had a kidney removed. So his rating was not done correctly. An organ removal, like a kidney, is according to the rating schedule, it gets you 30%. He was given 0% for his kidney cancer. So that's just short why I was a little late getting on. The problem with the comp and pen exams is real. I do quality reviews on the work that the folks who gather the evidence do. And so they're the ones, by and large, submitting these exams. And the best way I can describe it is it's completely not veteran-centric, which is what the VA tries to say they're doing. And thank you for that stat, Suzanne. 90% of the exams in fiscal 2021 were sent to contractors. When I'm reviewing a claim and I see a claim, an exam request bounce back and forth between VBA and the contractor multiple times, it's because the system that is in place to get these exams done by these contractors, it's almost as though every veteran service representative who requests an exam outside the VA system, they're administering a government contract. They're not requesting an exam and helping a veteran. They're administering a contract between VA and these contracted these private sector providers. So you see things going back and forth multiple times, and now it's not on every single claim, but it's on more than half of the claims that I see on a regular basis. So not only do veterans generally have to wait longer, excuse me, I'm getting over a cold, so the more I talk, the worse my voice gets. Not only do these veterans sometimes have to wait longer, they end up going back and forth sometimes because the examiner doesn't do their job correctly. And they don't address all of the things that the folks who prepare the ratings, which assigns the veteran their disability percentage, and in many, many, many cases allows them to get care at the VA. They don't have the training and the knowledge to properly address the conditions that these veterans have. Whereas obviously inside of VHA, if they were doing the compensation and pension exams, they're so in tune with veterans healthcare already. These are, providers who work for the VA, that they know which questions to ask. and how to work with those veterans to get those exams done correctly. They know, if for nothing else, they know the lingo of how these things need to be done. I don't know what else you want me to say.
Dave, that's great. And one of the recommendations that we have in the report is obviously that there be more staff at the VBA, and that the talk time requirements that limit the amount of time that claims processors have with veterans be reversed, but also that we go back to a system in which VHA staff, clinicians are the ones who do the CNP exams, and that there's a dedicated cadre of VHA staff who do that, as opposed to asking VHA staff who deliver clinical care to somehow squeeze in a CNP exam in their time, which takes time away from veterans. So we obviously hope you all look closely at the report, but I want to return to some of the issues raised in the VHA. One of them, and Jim Martin, who's an emergency physician, a longtime emergency physician who's worked in the private sector and at the VA in Chicago, he describes the problems of the kind of fragmentation of care that he experiences when he tries to take care of veterans in his ER. Now, I do want to contextualize this, that Russell mentioned how superlative the care is at the VA, and a study, 3 studies actually, which are mentioned in the report, have been, one was published by the British Medical Journal, and they looked at ER visits of over 500,000 patients who went to who had Medicare and VA, and who went to an either private sector ER or a public sector ER. And the veterans who went to private sector ERs were twice as likely to die in the first 28 days as those who went to VHA ERs. And this was due the survival benefit in the VHA, the 3 economists, investigators found, was due to the VA's superlative coordination of care, which is being eroded when veterans are divided in the private sector. And Jim, I'd love it if you tell the story of your cardiac patient that you saw recently. So I'm going to turn it over to Jim Martin.
Well, hello, everybody. It was a weekend shift, and this gentleman came in with chest pain. He was in his 70s. 2 weeks prior, he had a cath done at an outside hospital, catheterization. And I didn't have they did scan the file, a PDF file. So I had 82 pages of a PDF file that I had to go through now with the guy having chest pain. So I'm flipping, I had to print it out because I couldn't go through it online. It's too much to go through 82 pages on a computer screen. So I printed it out and I got to it really quick. I didn't have any EKGs to compare with. That was a disappointment. And so anyway, so we're down a cardiologist in our hospital. So about 1/3 of our cardiac patients are being referred out. And once they get referred out, the documentation is becoming fragmented. We don't know really what's going on. We can't get their EKGs. We'll get a summary, but it's just not the way it used to be. We kept everything in-house, and now we're sending it out, and we're losing this information really forever. So little by little, we're destroying what we've built up over the years. And this was and can be, I want to say it can be the best system that it ever was. I really hope we can maintain it, because right now we're competing with the outside hospital cartels, and they're trying to hold on to these patients. Once they get them, they start working them up and doing tests that we should be doing. I mean, we're sending them there for one issue, and they're winding up being overworked up. So it's really a disappointment. I've noticed the change. I've been here for 17 years, and this change has occurred, well, I guess since 2015, 2016. But it's really disappointing because we had something so good.
And I do want to say that, you know, even though these are staggering assaults on the VA, as Jasper said, all the studies show that even with, you know, one hand tied behind their back, the VA still delivers better care than the private sector. And I think that we need to look at the kind of experiences people like Jim are having and the difficulty of you know, caring for these patients and the frustrations, and really take this message to heart. I'd like to ask Linda Ward-Smith to talk. She works in the Office of Community Care in Las Vegas, and she's going to talk to us a little bit about how difficult it is. The VA is mandated to coordinate care with the private sector, but the private sector isn't mandated to coordinate care with the VA. The private sector, the VA has these very strong quality standards and wait time standards it has to abide by, but the private sector doesn't. I mean, it's quite extraordinary how this has been constructed. And Linda will talk about, you know, the frustrations of trying to get records and documentation from the private sector, and how staff are also, more and more staff are being diverted to this effort. Linda, do you want to speak to the group for a little bit?
Yeah, just real briefly. Good afternoon, everybody. I just wanted to take you through a normal referral process. So normally what happens is if a veteran cannot be seen within 28 days with the provider in the VA system, you guys know we send them out, and a referral goes to the RN at the community care department. And then the RN or the administrative staff will process the consult. And then we send that out to the private community doctor. So then once that veteran get an appointment, usually within hopefully 30, 60 days, hopefully, veteran is seen. And then what happens is the RN or the administrative staff now has to try to hunt down the medical records to find out what was done in the community by the private doctor. Then if we cannot obtain those records, that record unfortunately is just closed out administratively. And we unfortunately don't even get the records back into the VA system. We just close out the records sometimes, and not knowing what actually care was done in the community, which is unfortunate for our VA providers, because, you know, although we sent the patient out into the community, we have no idea what that community care provider did. But the sad part is that provider in the community still gets paid, because there's nothing really written in the contract that says, if you don't send us records back, we don't pay you. And I just think that is really a disservice to everybody, because now that VA provider, not only is he guessing what happened, but he's now trying to fix it, of course, because we do everything in the VA system. We take care of our veterans. And so we're now trying to guess what happened and then take care of the veteran when he comes back to us. So I think we can do better for our veterans. So yeah, I just wanted to share that. So thanks, everybody.
Yeah, I just want to quote from a psychologist who was quoted in our report, and she said that you know, despite the best efforts to coordinate and monitor care in the private sector, it can be almost impossible. We are sent faxes that are uploaded into the computerized medical record. Most are handwritten and largely ineligible. If you can read them, they contain such minimal information that it's very difficult to make a clinical decision. Generally, what we're left with the uncertainty of what decision do I make here? the word angst comes to mind. This is very upsetting work. And, no wonder people feel burned out and want to leave. The last speaker before we go to questions is Barb Galey, who's in Minneapolis. And one of the things that we documented was the large amount of programs and beds and services that are being closed absent the AIR process throughout the country, and because of short staffing. And Barb has a very current example of what's going on right now that she's going to tell us about. Barb, do you want to take the floor?
Thank you, Suzanne. Appreciate it. Hello, everyone. I'm the president of Local 3669 in Minneapolis. Minneapolis VA is a 1A facility, meaning we take ambulances, we do surgeries, we do all of it. We're the biggest hospital in VISN 23, which represents North Dakota, South Dakota, Iowa, Nebraska, and Minnesota. We got a proposal that they wanted to close the post-op surgical floor. We had two. They closed one well over a year ago to convert it from a 30-bed unit to a 16-bed private room unit. That has not opened yet. So they want to close the 30-bed unit. They don't know why. We asked them last week on the briefing. There's no plans for the ward. All they could tell us was that the nurses said they don't like caring for medicine patients. So we asked for some numbers, and I did just get them that I'd like to give to you, because they're saying that the OR, the number of operations cannot support keeping a 30-bed ward open. So we asked for pre-COVID surgical numbers, because as we all know, everything drastically changed with COVID. So in 2019, there were a total of 2,461 patients admitted after having surgery, which means that they went to the post-op surgical ward. In 2022, there were only 890. Now, those are COVID numbers. Operating rooms are supposed to be on the uptick. We're supposed to increase our surgeries and get back to pre-COVID numbers. The operating room staff is short, like everywhere else, but they are hiring. So that should pick up fairly quickly. The other huge concern to me is that since COVID, we have a huge number of veterans being boarded in the emergency room. They can be boarded in the emergency room for anywhere from 12 to 36 hours. The number of boarders for 2022 was 1,051. Veterans get boarded because they need to be admitted, but there is no place to put them, whether it be because there's no bed or there's no staff. I will take it upon myself and just say there's no staff to staff the bed. However, closing a 30-bed unit is going to increase that number exponentially. It makes no sense. We're just forcing the VA into sending these veterans out to vendors. And that's what I'm going to refer to them as. They are vendors. They're competing for our patients, and our patients deserve better than that. And that's the type of care that we have always provided.
Thank you, Barb. So I want to conclude by and open it up to questions, but I want to conclude by saying that what you've just heard is just a smattering of what we hear every day from the front lines. And we have a healthcare system that we have invested in this country for 70 years that delivers some of the best care for anyone, that also serves the nation as a whole through its teaching, research, and fourth mission. And this is being eroded, deliberately eroded by policies that the Biden administration could reverse, but seems not to want to reverse. And what could they reverse, and what could they do without going to Congress at all? Well, obviously they could reverse the Human Resources Management Modernization Project that has taken local HR staff out of local VAs and put them in a central office, and they're unreachable. I'm going to ask Eric Gherkin, if he's still on, to describe something that one of his colleagues told me about Reno in a minute, but that can be reversed and staff can be returned to the local level to make the already cumbersome hiring process at the VA better. The secretary and the undersecretary for health insist that they are hiring more staff, but the question is, what kind of staff? Who are they hiring and where are they working? Are they working on the floors? Are they working to take care of veterans, or are they working in the Office of Community Care, the referral coordination issue? Are they administrators? That's something we need to know. We applaud any efforts to hire more staff, but it's clearly not enough to deal with the 70,000 vacancies. When I started writing about the VA in 2014, there were 34,000 vacancies. Now there's 70. We think that the VA can be advantaged rather than disadvantaged by reversing the drive time and wait time standards that you heard Linda talk about wait times at the VA being 28 days and veterans are sent to the private sector. And she talked about wait times in the private sector of 30, 40, or 60 days. How does that make sense? And we know the wait times are longer in the private sector. These drive time and wait time standards need to be revisited and revised. One very quick thing the secretary could do that we recommend is right now, according to the Wilkie standards, if you get a telehealth appointment in the VA for anything tomorrow, that doesn't count as access to care. If you get a telehealth appointment in the private sector in 3 weeks, that counts as access to care. The secretary has said that this should be revised and telehealth in the VA should count. He can start that process through the Federal Register tomorrow. He has not, and that should be done. Jasper, do you want to chime in? I'm with other.
Sure. Yeah. Well, just a couple of quick things. I see there was a comment from Jennifer Johnson asking about solutions here, and just to note that on page 39 of the report that I linked to at the top, that's where we lay out a lot of these policy prescriptions, things that can help improve the system. Suzanne just mentioned one of them, but there are many more. I mean, you know, the piece gets into explicit detail about the major obstacles in hiring and onboarding staff. We have a lot of survey data showing that engaged prospective candidates end up basically seeking private care pastures because the system to get into the VA is just so vexing and arcane. That's one issue here that can help with staffing and proper resourcing. I mean, fundamentally, at the end of the day, is a lot of nuance to these issues, but you know, it ultimately comes down to money and staff and support. Because basically what you enter into and what is happening now is a vicious cycle where under-resourcing has created, you know, further under-resourcing, further burnout. People leave because they're not supported, and it's accelerating in a disturbing way. So if you want to go to page 39 of that report, you can sort of see in pretty basic detail some of the things that can help with these issues. There are, of course, more. I mean, AFGE and VHPI have been proposing policy fixes for years now, and on our website, we talk about a lot of them. Let me just put the report in right there. I also see that Russell just got back on. Russell, I don't know if you want to talk a bit more and sort of finish out your thoughts before we get to other questions.
Well, I think Russell, if he's going to talk, should really focus on solutions, because I think that's where the group really wants to focus on. So Russell, I would encourage you to do that if you have anything to say further. Is Russell there?
I don't know, he may be having weird connectivity issues. There's a number of really good comments and questions. There was also one I noted from Jen Embry. She writes, the community electronic health systems are typically connected by a health information exchange system. Does the VA not have the ability to access these records electronically? I am not sure how I got invited to this call. She talks about being from a Big Ten research university. Does anyone want to talk about the disconnect between the private sector and the VA when it comes to electronic records? Maybe Linda?
Linda?
Sorry, guys, I was trying to come off mute. Several things with the electronic record. As you guys know, Cerner is a big deal. We're a test site here in Las Vegas. They're having so many issues with Cerner, of course. With the exchange system, my understanding is they do have the Veterans Health Exchange where you can upload medical records into this exchange system. However, for the community care providers, they can opt in to utilize it. And a lot of the providers have not modernized their systems in order to take advantage of this program, electronic program. So their systems are antiquated still. So they're still faxing, and that's where their provider comes in and says she's still dealing with faxes because providers are not doing it. So that's the problem. I hope that answers the question.
Yeah, that's very helpful. If there are any other questions, folks can put into the chat. A while ago, Rick, is Russell still there? Rick Stagenberg asked.
Yeah, can you hear me now?
Yeah.
Oh, sorry. My entire system went down for a half hour, but I can at least talk.
Great. Yeah, so Rick wanted to know how shortages, mental health shortages compare between VA and private sector. I don't know if you want to talk about I think that's a good jumping off point to talk about some of the potential policy fixes here.
Rick, I don't think I have the data to confidently answer that question, other than speaking more broadly, of course, as we know that in between a third and a half of all the counties, particularly rural counties in the country, there are severe shortages, and many of them have no psychiatrists at all. But I'm not sure, in terms of the question that you're posing, that I have all the data at hand. I did come back on right when Suzanne was talking about counting telehealth. That is particularly relevant for mental health. The data during COVID is that the majority of the telehealth visits were done for mental health. And I think that although that's come down a little bit across the board, it's still predominantly a mental health function. And so it makes the recommendation that Suzanne was reiterating earlier, that if you count telehealth availability within the 20 to 28 days as access to care, it's $1 billion saving for the VA on a yearly basis, according to the VA. And it helps with the access issue that Suzanne was talking about, and it actually expedites quicker and better care. So it handles many different pieces pretty readily, and it's something the VA could do pretty quickly.
Yeah, I also want to mention a couple things that are really in play right now. The budget, the president has just released a while ago his budget request for 2024 for the VA. And we've analyzed it. We looked at the budget discrepancies between the amount of money in the VHA clinical care budget goes to the private sector, and between 2017 and 2022, the budget for private sector care increased by 116%, and the budget for clinical care in the VA increased by 32%. The VA secretary has said that he wants this share, which is now 35% of clinical care budget going to the private sector and 65% to the VA, to go down 25% of the private sector and, and 75% of the VA. But the president's 2024 request continues this discrepancy between increases in the VA in-house budget and the external budget. And Jennifer, one of the things people can do is put pressure on the HVAC and SVAC committees and the House and the Biden administration and VA leadership to do what they must do to not give so much money to the private sector and so little to the VA increases. And that would be done, that can be done by revising the drive time and wait time standards. Another thing that's in play now is the VA is renewing its contract with the third-party administrator. We are unable to get copies of the contracts, but from what we know, the TPA, the third-party administrator, which is now TriWest, gets a kind of head tax on every veteran, a per member per month fee for every veteran that goes into the private sector and stays in the private sector every month. So they have an incentive not to send people back to the VA and to keep people in the private sector for as long as possible. It's financial incentive. There are also no requirements in the contracts as written now that the private sector providers have to know anything about veterans' complex health issues or military cultural competency. And there is apparently a discussion that we can all influence now going on inside HVAC and SVAC and VA about requiring private sector providers to at least have minimal competence and knowledge about veterans' complex issues and military culture. The TriWest, CEO Dave McIntyre is fighting that and saying that private sector providers won't join the network if they're required to learn how to better care for veterans. I think that's unethical. You would not go to a surgeon who said, I'm not going to learn the latest surgical technique, and we shouldn't be paying taxpayer money to private sector providers. We need to impose the same quality and wait time standards on them that are imposed on the VA, and that's another of our recommendations. And this is, I mean, you all know, because this is your job, that putting pressure on legislators is what causes changes in their behavior. We saw this with the Air Commission, AFGE and other groups led, huge alliances that protested the proposal to close facilities, and that was ultimately killed, the Air Commission. And we can do the same thing to protect future veterans and to protect the integrity of the VA.
Yeah, absolutely. I think that's a great point, Suzanne. So if there are any other questions, folks should feel free to put them in the chat or raise their hands. As we've all said, what's been covered today is a small fraction of the report's findings. As you'll see, there are 2 detailed appendices that break down our survey responses. There are historical and analytical sections tracing how some of the major VA issues we see came to be. We also end the report with a series of testimonials from VA patients that express real urgent concerns around the outsourcing of care, but ultimately exemplify how fantastic VA staff are in delivering this care while facing, outright hostility from certain factions of Congress. And so we invite you all to read the report, to distribute it. We'll be working over the next weeks to get this report out into the world already. There's been some fantastic news coverage. The VA secretary himself, Dennis McDonough, has read the report and said it has been useful as he attempts to increase hiring inside VA. That's certainly an encouraging step, but we are not going to let up on this work. And again, I put my email address at the beginning of the call, but I will just paste it back here. Folks should feel free to reach out to me if they have any follow-up questions, or want to get involved with VHPI, or are looking for specific resources or help, because we are pretty well connected in this world. So if no other questions pop up, I think that we're probably able to wrap up the forum. We want to thank you all for taking time out to hear this work, and we want to thank all of the veterans and VA employees and AFGE members here on the call supporting us. So seeing no other questions, I will end the meeting here, and again, thank you all for